Today, I think as you noticed, those who are here for the first year of seminars, I'm trying to really mix basic research on ion channels and substrates and all of the basic molecular and up research on cardiac arrhythmia mechanisms, together with clinical applications and translational research, which is a buzzword these days. So today we have a great speaker and an opportunity to hear what's done on the other side of the metro line at Children's Hospital. And Dr. Singh, who will speak to us today, is, he defines himself as a pediatric cardiologist who does imaging in children. Yes, that's his. But he is also co-director of the Echo Laboratory in Children's Hospital, and also directs the non-invasive cardiac imaging research. And he'll talk to us about Speckle's technology and its application in children, especially in resynchronization therapy. So, thank you for coming.
Thank you. Thanks, Dr. Rudy. Thanks for the opportunity, and I hope you will all be able to hear me at the back. I'm going to present some application of tissue Doppler and Speckle tracking in clinical practice and in research both. Before I do that, I want to start way back when one of the French morphologists in 17th century, who dissected the heart and found out that heart is made of individual fibers, and each fiber has the capability to contract, and it's the total sum of the, or aggregate of all these contracting fibers which provides the heart muscle to work, and work as we know the heart. So it's easy to understand that in a heart which is already dissected and which is already, you can look at it, individual fibers, and understand its mechanism. But in a heart which is functioning in a situation in patient or in utero situation, you cannot study the individual myocardial fibers, and you cannot understand the different its movements and deformations and other things which comes with it. And so there is a sort of knowledge gap in understanding of normal structure and function of a beating heart, not the exercise heart, but its beating heart, because of the complexity of the myocardial fiber orientations and its structure, and how heart contracts because of that unusual or rather complex myocardial fiber arrangement makes it difficult to study the myocardial mechanics. And of course, its regional function, although we do understand the global function to a certain extent. So what I'd like to do to present in this talk is to explain some of the cardiac mechanics during cardiac systole when the heart contracts, during diastole, and see how we can apply some of the newer cardiac imaging modalities, namely tissue Doppler imaging and the Speckle tracking, to understand the cardiac structure and function at a sub-macroscopic level, and that's what we would try to elucidate. Also, we'd like to see how we are applying that in clinical practice and some of the research, not only in children but mostly in adult side. So, starting with cardiac mechanics of systole and diastole. So, heart, as you know, that cycles between two states. One is systole, another is diastole, and it's very fascinating in the sense that during systole, heart is a very stiff chamber which rapidly contracts to inject the blood to meet the demand of the body activities, or what we call stored volume. But next cycle, it becomes a very compliant chamber, from a very stiff chamber to a very compliant chamber, which has to accommodate blood coming from a low pressure chamber in the atrium, which is the upper chamber, to the ventricle, which is the lower chamber. and that goes through a very rapid sequence of mechanical and electrical sequence and that's very coordinated, and this cycle is repeated all the time. So heart is a very efficient pump, and it works between these two cycles, and this is entirely facilitated by this, orchestrated by myocardial fiber architecture, an electrical sequence and mechanical sequence which follows this. So myocardial fiber architecture is an important part, how it happens, how the heart is excited by electrical sequence, and together how they result in a mechanical sequence which results in cardiac output and cardiac relaxation. So heart, the morphologists have tried to analyze the myocardial fiber orientation for quite some time. In recent time, there have been a lot of research knowing about myocardial fiber orientation, and some of the accepted facts are that the myocardial fiber are arranged in a sort of helical fashion. So subendocardial fiber, which is next to the left ventricular cavity, they are arranged in what we call right-handed helix, whereas subepicardial means just below the surface, external surface, they are arranged in left-sided or left-handed helix. So this provides a sort of myocardial fiber architecture which are very counter-directional to each other. The right versus the left, the internal or subendocardial versus the subepicardial. And together they end up in a very distinct movement which are very counter-current or counter-directional. This is facilitated by the electrical activation of the heart, and the electrical activation starts in the apical endocardium and travels from apex to the base and from endocardium to the epicardium, from inside to outside, traveling ultimately to the apical part or in the epicardium, and that's a apex to base direction. During repolarization, when heart relaxes, it's entirely opposite. The electrical sequence starts from the base and goes towards the apex, but it goes from endocardium to epicardium against the same sequence. And the last part which becomes repolarized is the subepicardial region at the apical region. So again, the sequence is also counter-directional, which along with the myocardial fiber orientation, which are helical, they facilitate the movements which are very distinct, and that results in cardiac systole and cardiac diastole, so the mechanical sequence. So during cardiac systole, the heart contracts, the two helix contracts in opposite direction, apex to base in the subendocardial region, and base to apex in subendocardial region. And also this creates a apex to base and subendocardial to subepicardial contraction gradient. So the pressure and the gradient is highest in subendocardial region and results in a apical counterclockwise and a basal clockwise long axis rotation. So heart not only contracts in longitudinal and circumferential, but actually is it's a circumferential direction, and it's just like if you wet towel and you squeeze it, you can see that the breathing movements leads to a complete ejection of the blood from the ventricle. So this is a myocardial fiber studied in a pig heart, which is live, and all the layers, and you can appreciate that the layers are going, the subendocardial layers are different than subepicardial layers. The subepicardial layers are going this way and the subendocardial layers are going this way. And this counter-directional motion of the heart is pretty much depicting what the myocardial architecture is, myocardial fiber architecture is. And this is tracked by one of the newer modality or relatively newer modality, what we call Speckle tracking, about which we'll talk in subsequently. And as we said, the base of the heart, which is depicted over here, and the apex of the heart is depicted here. The base moves clockwise, and the apex moves counterclockwise, and that provides the so-called breathing motion of the heart or ventricles, which leads to complete ejection of the blood from the cavity of the ventricle towards the red blood vessels. So this is again studied by Speckle tracking, the newer modality which we will talk about in subsequently. cardiac diastole is just the reverse, the opposite. Relaxation is where the two helices moves again in opposite direction. The myocardial fiber orientation is such that there is a base to apex to base subendocardial motion, and there is a base to apex subepicardial motion. And that leads to a complete unreading or counter directional motion, which creates a active apex to base and subendocardial to subepicardial relaxation gradient, which results in diastolic suction. So this diastolic suction is not a passive phenomenon, just heart doesn't relax. Actually, it's a very energy dependent mechanism, which results in as if the blood is sucked from the upper chamber to the lower chamber. It's not the upper chamber which is pushing the blood to the lower chamber. It's an active process of suction to the lower chamber or ventricle. And that's how it works later on, toward later half of the diastole, or then the upper chamber contracts and sends the blood down. So that's a very distinct motion. So here is an example of a myocardial fiber during diastole. There are differential fiber motions. They are tracked by Speckle tracking. The upper one is subepicardial. The lower one is subendocardial. Subendocardial is moving towards the center of the cavity, where the subepicardial is moving away from the cavity, and that provides a counter-directional motion. And during the early phase of relaxation, heart completely is standstill, but the tension in the wall motion completely goes down, and that leads to a lowering of the pressure in the left ventricle or ventricle, which leads to filling of the ventricle. So this is one of the examples which has been also, you can see that these are the high fidelity M.R.C.P, which is showing the different layers of the fiber. These are the subepicardial fibers. These are the subendocardial fibers. The cavity of the heart is on the ventricle is on this side. And this is moving upwards or outwards. This is moving towards the cavity, and that's also depicted by the waveforms which has been generated from the wall motion. So the epicardial fibers are moving out, and the endocardial fibers or subendocardial fibers are moving in, providing a stretch to the ventricle, and thereby, and also lowering of the tension in the wall, and thereby creating a suction to the ventricle. So all this was not possible to really study them in a beating heart, and some of these newer techniques or modality have facilitated this kind of study both in research as well as in clinical practice. Just to show the same thing here, during systole, the apex of the heart moves counterclockwise, base moves clockwise, and during diastole the movement is just the reverse. The apex moves clockwise apex moves clockwise and base moves counterclockwise, and you can see this kind of motion creates a torsion, and that certainly during systole helps to inject the blood to the great arteries. I'll move to that. So this result in the motion or movements of the blood. So this is a vortex flow generated by a contrast and using a particle imaging velocimetry, where you can see the blood is flowing from the left atrium or left upper chamber to the left ventricle, which is left lower chamber, and it creates a vortex, and the vortex is a way to conserve the kinetic energy in the heart, and it goes up and then swirls around and goes out of the outflow tract, which is over here. And this provides an efficient way of conserving energy and improving the mechanical efficiency of the heart. If you track the individual blood flow and provide again by particle velocimetry and provide the vector, means the direction as well as magnitude, which is depicted by the orientation of these arrows and their length, you can see the blood comes from the left upper chamber to lower chamber, and then it goes out. In this case, the outflow tract is over here, and in this case, it's on this side. So it's swirling around, creating a vortex and creating a very efficient manner. So during diastole, the blood flows toward, systole, blood flows from the base toward apex and comes out and outwards towards the outflow tract. These are the stationary images. and during diastole it goes towards the apex. And this is a normal motion of the blood flow generated by the counter mechanical sequence facilitated or orchestrated by the counter-directional myocardial fiber orientation and the electrical sequence. If you look at a heart which is not functioning well, where the myocardial contraction and relaxation is not synchronized, the myocardial fibers are abnormal, then you can only see that the blood is just swirling around and is not going out of the from the left lower chamber. And this is what we call dysynchronous wall motion and mechanical sequence, which are abnormal, leading to abnormal wall motion and poor cut ejection. And you can see in this image of vortex, they are just simply forming and they are staying inside the heart and they are not going out. So all these things can be studied by the newer modality, and some of the newer modality which we'll talk about is tissue Doppler, how we can apply this in studying the myocardial fiber orientation or myocardial fiber motion or myocardial velocity and deformation. So tissue Doppler basically follows the Doppler principle. If we put in a heart a gating and put the point of integration by using Doppler, it gives different kinds of velocity. Basically, it follows the Doppler principle, and which is showing that what's this shift in the frequency of a transmitted sound waves to a moving subject, which is moving towards the probe, and it causes a shift in the transmitted frequency. If we sample them at one time point, the so-called gating, then we can obtain a frequency curve and with their amplitude. And we apply this well-known equation where you can measure the velocity using the frequency, shift in frequency, transmitted frequency, angle of insolation, and the sound velocity, which provides the velocity of the moving object against which it was the Doppler was sent. So we can measure the velocity of this moving object either going towards the transducer or going away from the transducer. And once the velocity is known, then you can work with that in many ways. One of the ways is that you can measure the myocardial velocity as the heart moves, and you put a high-pass filter eliminating high velocity, low amplitude frequency from the low velocity and high amplitude velocity of the myocardial wall, and then you can get all the myocardial velocity here. So here is the myocardial velocity during systole and diastole. Here is this during systole. Here is the electrocardiogram showing the QRS and ST and T wave end of systole. During that systole, you have a waveform which is going towards the transducer, which is over here, and we have an upward waveform. And then during diastole, during very early suction of the blood towards the left ventricle, this is a rapid myocardial velocity during early diastole, and then there is a late myocardial velocity during late diastole, and we can measure all this. And this has come in clinical arena without has been now used for quite several years, and it's a very robust method of measuring myocardial velocity. So we can just to illustrate, we can use besides Doppler, we can use the color Doppler, and we can measure the velocity in multiple views. We can measure the velocity of the base of the heart, the different segments of the free wall, the septum, the right free wall, and we can even measure the velocity of the atrial wall and measure them with very precise way. And this is what, as we elucidated earlier on, you get a systolic velocity, diastolic velocity. Diastolic is E prime and A prime. And between the systole and diastole, the period is called isovolumic relaxation time. We can measure that time. And during diastole and during systole and diastole, we can also measure isovolumic contraction time when heart is contracting but is not ejecting. And with all this velocity measurement, we can also apply in clinical arena. Here is an example of a normal velocity in a child who, adult, which has a normal myocardial velocity, and this is a adult with left ventricular hypertrophy because of hypertrophic cardiomyopathy. There is early diastolic flow velocity is decreased, myocardial velocity is decreased, and the late is normal. And this provides just the reverse pattern than what we normally see. The early diastolic velocity is higher than the late diastolic. So this gives a impression that there is a diastolic dysfunction. This is a myocardial velocity in a child where both early and late, they are almost fused and you can't discern that. So certain pattern recognition has provided some idea about how you can measure, how you can discern some myocardial disease. This is the same using the color Doppler, and we can sample the myocardial velocity at different points at the base, midpoint, and the apex, and it can provide, these are the different, these are the three different sites providing three systolic velocity and the three diastolic velocity early and late. It not only provides the velocity, also provides the depth, what's there, the time from the onset of the QRS, and in the direction of the myocardial velocity. So it provides a part of the vector of both direction and the amplitude in that sense. Not only the myocardial velocity, we can measure the blood flow through the valves or in different parts of the heart by putting the Doppler sampler in appropriate position. This is a Doppler sample put in the between the left ventricle and the left atrium at the level of the tip of the mitral valve, and you can see the early diastolic flow velocity, late diastolic flow velocity, and you can measure between systole and diastole diastole contraction time. And they have been, and you can see the pattern. We can also measure how fast the velocity comes down, and we can measure deceleration time from the peak, which gives idea about the myocardial stiffness. So that can also be measured in a very precise way. Not only that, if we combine both myocardial velocity as well as blood flow velocity, then and put them together and take the ratio. For instance, take the ratio of the early mitral valve flow, diastolic flow velocity with early myocardial velocity. This ratio called E to E prime ratio, and their ratio gives us the idea about the function or actually the pressure in the ventricle. So this is pretty much one thing which has come in practice, and we can measure what's the ventricle pressure. If it is less than 8, then it's normal. It's more than 15, excuse me, then it is abnormal. So there's a lot of information one can derive. So for instance, there is a patient with a dilated cardiomyopathy where the heart muscles is weak and is not contracting well, and here the E to E prime ratio is 40, much higher than 15. So left ventricle diastolic pressure is very high, and I think it's as high as about 20 to 25 millimeter mercury. So we can get the idea just by very non-invasive way how we can measure all those pressure in the ventricle. So I'll move on to now Speckle tracking, how we can apply the Speckle tracking in measuring the myocardial deformation and myocardial strain and strain rate. The Speckle is basically a inhomogeneity in any tissue, and if you send a waveform through the transducer, it goes and reflected back. If you send another one, if there is more than one area of inhomogeneity, then the other waveform comes and interfere it. And tissue is nothing but a bunch of inhomogeneous structure which provides a multiple waveform returning, and they are interfering with each other, and that provides a very complex waveform pattern, and that waveform pattern can be translated into a certain pattern which can be translated into a brightness and mode, and we can have different brightness, which gives idea about different myocardial fiber orientation and structure. So this is what the Speckle is, and this is what in a heart it looks like. You can see the different brightness and darkness. These are the little speckles you can see all along there, and these are the different patterns which we come to recognize. It's of course is defined by the size and shape and the spatial orientation of the scatter, and imaging system which has been used like beam width and filtering and all other can affect it. And there lies the pitfalls in some of measuring the speckle when we track it. So what we do is we see the speckle in one area, and a speckle in any area provides a natural acoustic marker, and actually provides a fingerprint of that area. And when the heart wall moves, and in next movement we can trace it, and we can trace the entire speckle from one frame to other frame, just like this, and then we can measure how much movement and change in shape has taken place, the so-called deformation. And by doing that, by frame tracking of this speckle, we can measure the myocardial motion, myocardial velocity, myocardial deformation. So yes, speckle tracking has provided one way of not only measuring the myocardial velocity deformation, but also myocardial fiber orientation, which we can allude to that later on. So here is a speckle tracking in a fourth chamber of the heart, where we are seeing the left and right atria, left and right ventricle. Here is the outline where the speckle has been tracked, and it has provided deformation. It can also provide the torsion, the degree of twist of the myocardial ventricle, and torsion rate. Deformation is the one area where we have delved into, and we like to just elaborate about that. So deformation or a strain is a dimensionless measure of the structural deformation of any type. And in a linear strain pattern, this is how we can just depict it. There is a myocardium which is in relaxed state, and during contraction states, there is a change of length from diastole to systole. So the percentage change from the original length is what the strain is, which I don't have to allude much to this audience, but this is a basis for measuring the strain in the heart. And heart is such that it doesn't move just in one dimension, it moves in 3 dimensions. So here is a longitudinal change in length of the septum from the diastole to systole, and you can see the length has changed from diastole to systole. There is an amount of deformation which has taken place compared to the baseline or the initial length. But heart, as it contracts in longitudinal direction, actually it widens or thickens in other direction. It follows the law of conservation of the mass, and you can see that as the heart contracts towards the cavity, the wall becomes thickened. And so this is what we call radial or transverse deformation besides the longitudinal deformation. So the heart actually contracts or deform in 3 dimensions. And these 3 dimensions are longitudinal, circumferential, and then radial. And if we look at those in a sort of graphic fashion, you can see they are circumferential, they are tangent to the cavity of the ventricle. Longitudinal is almost perpendicular, and radial is across the thickness of the wall. So they are perpendicular to each other in 3 dimensions. So heart has 3-dimensional deformation. Actually, it has 3-dimensional deformation and 6-dimensional stress. So, but we don't go into that. We measure deformation in 3 dimensions, and it has provided a relatively less load-dependent sort of modality. If we measure the function of the heart in terms of the conventional measurements, what we call ejection fractional or fractional sorting, is how much heart has contracted by volume-wise from diastole to systole, and how much it has ejected. So degree of ejection which has taken place has called ejection fraction. But the ejection fraction is affected by many factors. Heart rate, what's the afterload, means what's the blood pressure, what's the preload, means how much heart is filled, and many other factors. They can all affect the conventional measure of the myocardial function. But a strain, and particularly a strain rate, they are relatively load independent. Actually, a strain rate defines what's the contractility of the heart. So I think using a strain and a strain rate, we get better idea about the intrinsic function of the myocardium itself, not the heart as a whole, but more so at the sub-morphological level, more like at myocardial fiber level. So this is, we can measure the strain in longitudinal direction, along the longitudinal direction of the heart. This is, we get a graphic forms, and we get different waveforms and different segments. Here is the 4-chamber view of the heart, the 2 basal, the 2 mid, and 2 apical. We can measure the deformation and velocity in each of these 6 segments. In this view, we can apply 2 other different views, means total of 18 segments we can measure, and we can measure their global strain as well as individual strain of each segment. So we can measure the strain in 18 segments individually, or we can measure a aggregate effect of the total segments in form of global strain. So here is a global strain and the segmental strains seen in different colors. The dotted lines is showing the global strain. This is the peak strain, longitudinal strain. This is the latest strain, and then diastole starts over there. So this is a longitudinal strain. There is the live, the real time you can see, and here it is color coded. During systole it has a different color, during diastole it has a different color, and you can see the heart contracts and relax, and it provides different degree of deformation, which you can either measure in a color coding forms or a wave form, and this is quantitative. You can measure the degree of quantity of deformation. You can measure it in different segments of the heart. So that was the normal. So this was a normal heart where you can see all the segments are moving as in a synchronous fashion. They are having their peak deformation more or less at the same time, even though they are different segments. But if you look at this heart, this is a heart of an overweight child, which is showing the dyssynchrony of the different segments. The one which is at the base is contracting late. The one which is at the apex is contracting earlier, and one which is more towards the apical part of the left side is contracting the earliest. So they have what we call mechanical dyssynchrony. They are not contracting at the same time. Just looking at it, visualization provides that it's not a synchronous motion, but we can't quantify it just by visualizing. But we can quantify by this graphic form. We can measure the time of the peak deformation from the onset of the QRS, and we can measure how late or how early they are really contracting, and we can plot and give a color coding to the entire heart for the timing of activation of mechanical sequence of different segments. So this provides very useful way of measuring mechanical sequence of the heart. We can measure the circumferential strain at the same time, and this is a same adolescent who is overweight, and you can see this is circumferential motion of the left ventricle at the short axis, in short axis view at the capillary muscle level, and you can see the different segments which are color coded. They are moving in a delayed fashion and a different fashion. This is pretty much this synchronous motion of the different segments. So this Speckle tracking has provided a means of measuring deformation, the degree of deformation, the timing of deformation, and their direction. So it's providing basically a tensor in a way. You can measure a strain rate, which is a time derivative of a strain, and you can measure how quickly and how slowly the deformation is taking place. This is the systolic strain rate over here, different segment. This is early diastolic strain rate. This is late diastolic strain rate. Again, depicted in different segments from the different segments of the heart. So that brings how we apply this information in clinical practice, and this is what I'd like to elucidate, provide some translational things which is taking place over the last few years, and we'll provide their application in clinical arena. So we know the heart disease is the leading cause of mortality in the adult population in the country, and and the congestive heart failure is the most common way of manifesting the heart dysfunction. About 30 to 50% patients, they have diastolic function, and most of them may not have systolic dysfunction, but they have some degree of both systolic and diastolic dysfunction. So by applying some of the tissue Doppler, we have seen, at least in large clinical trial, that you can measure their velocity of the heart, myocardial velocity, early diastolic velocity in this case, was a very strong predictor of the survival rate in adult with congestive heart failure. So those in this large study published in 2003 of more than 4,000 patients population, the patients who were in heart failure with decreased myocardial velocity of less than 3 centimeter per second compared to those who have more than 5 centimeter per second, their survival was exponentially less and less with time over a 40-month period compared to those who had normal velocity or above 5 centimeter per second. Intermediate one between more than 3 and less than 5, they have intermediate result in terms of survival. So it does have some clinical application that we can apply, and we do apply in our clinical practice in discerning the diastolic dysfunction, discerning the myocardial function. Here is another study in where it was measured the ratio of the early diastolic blood flow through the mitral valve over the early diastolic myocardial velocity, the so-called E to E prime ratio. Those who had less than 15 means they were more in towards the normal, versus those who had more than 15 means their diastolic blood pressure, left ventricular diastolic blood pressure was high. Their survival was certainly much less over a period of 2 years compared to those who had low or near normal diastolic function. So E to E prime is a very powerful predictor of survival after acute myocardial infarction in the adult population, and that's seen across the board. So it's just not the it's just not the research, but it's very much applicable in clinical arena now. Here is an example of a patient that if you have a decreased contraction or what we call ejection fraction, then E to E prime ratio means measuring the left ventricle pressure by this E to E prime ratio provide even further information. So here is a patient with who has decreased ejection fraction, means their heart is contracting less, systolic dysfunction is there. But if they have normal diastolic pressure, their survival was better than those who have diastolic dysfunction because their E to E prime ratio was more than 15. In ejection fraction, less than 40%, means their systolic dysfunction as well as diastolic dysfunction, survival was much less, significantly less than those who have only systolic dysfunction. Even those who have normal systolic function, where ejection fraction was more than 40%, those who have diastolic dysfunction with a elevated E to E prime ratio, their survival was certainly less. So it has an incremental value in providing the prognostic outcome of the patients with heart failure or any cardiac dysfunction. Moving on to application of these tissue Doppler and Speckle tracking echo in cardiac resynchronization therapy, which is the not a new thing, but it's certainly the buzzword and is certainly applied more and more in adult cardiac patients and to a certain extent pediatric cardiac patients. What tissue Doppler and Speckle tracking has provided is that you can discern the mechanical dyssynchrony of the heart, which contributes to cardiac dysfunction. So, for example, here is the two hearts. This is the normal heart, normal person, and this is a person who has bundle branch block. Means there is a conduction in the heart is affected, and they have a left bundle branch block here. So you can and these are the radial strain which have been measured. You can see the radial strain is very synchronous. All the segments which have been tracked down, they all are contracting at the same time. compared to those who had left bundle branch block, and they are moving in a dysynchronous fashion. The one which is at the earliest activation versus the late activation, there is a time gap of almost 300 milliseconds. Usually the time gap between synchronous is not more than 65 milliseconds. So this provides what we call mechanical dysynchrony, and that provides the basis that it may be possible to synchronize the wall motion by putting different leads or pacing leads and try to synchronize them in order to make the myocardial motion more synchronous and homogeneous. Here is a Speckle tracking with three-dimensional volume sets where each of the heart segments have been divided into 16 segments, and they have been given volume, and they have been tracked, and they have been their displacement have been tracked. This is the normal, and this is abnormal. Here is the normal. All the Speckle tracking is showing very synchronous motion of all the segments of the heart compared to those who have very dysynchronous motion in all the 16 segments. So the advantage of using 3D Speckle tracking over the 2D, that we can measure all the 18 segments or 16 to 18 segments of the heart in one way at one time, whereas for 2D or 2D in 2 dimensions, you have to measure in 3 different planes to get to that 18 segments volume deformation and the strain and the strain rate. So this is an example of synchrony, mechanical synchrony, and this is mechanical dysynchrony. Here is an example again of a heart which contributing to myocardial dysfunction due to mechanical dysynchrony. This first we looked at it. This is another modality where you can measure the myocardial deformation, what we call by velocity vector imaging, where besides the Speckle tracking, you are also measuring the motion of the different segments of the heart moving away from the center of the cavity or moving towards the center of the cavity. And they have been different segments. Myocardial deformation is depicted by all this arrow, and the direction of arrow provides the direction of the wall motion. So this is the normal, this is abnormal. Normal, you can see that all wall motion is during systole is going towards the cavity of the heart and left ventricle, whereas in this patient of the cardiomyopathy with big myocardium, the septum is moving towards the cavity, but the free wall is moving away outward, and therefore this is a dysynchronous wall motion. So we can measure the wall deformation or strain in 2 dimensions by Speckle tracking, in 3 dimensions by same method, as well as changing in volume state, and by measuring the wall motion and applying the Speckle tracking in that way. Measuring in 3 dimensions, we can measure what's the earliest and what's the latest mechanical activation. So this is a bullseye view of all the 18 segments from in to out, from endocardium to epicardium. These are the different segments of the heart in 3D rendered volume, and you can see the apex and base there. And this patient has a left bundle branch block, and the earliest mechanical activation is at the base over here, basal anterior part of the septum, where the last or latest activation is more towards the apex right over here. And you can see the difference in this graphic presentation. The latest is, which is at the apex shown in this green color, is the last one, whereas the earliest is right at the beginning, which is at the base. So there is a difference between the wall deformation, and there is a marked dysynchrony between earliest and the latest mechanical activation. And this provides what's the degree of activation, the degree of mechanical dysynchrony, and what's the amplitude of the dysynchrony by measuring the time difference and the degree by the difference, how many segments are dysynchronous and where exactly they are. So this is a left bundle branch block patient with having a dysynchrony. Here is the patient who has pacing, the right ventricle is being paced at the apex of the heart. So the electrical activation is in a very different sequence than the normal activation, and therefore mechanical activation is also very different. In this heart, you can see that the earliest activation is the apex of the heart, in the septum right over here, whereas the latest or the last activation is at the mid-level, at mid-lateral wall of the right ventricle. And these are all illustrated in this very chaotic sort of activation of different 18 segments. But you can see the earliest activation is there, the latest activation is there. So there is a marked dyssynchrony, mechanical dyssynchrony of different segments of the heart, which you can map out in 3 dimensions. So how we can use that? The studies are already there, and they have found out that if you have a mechanical dyssynchrony, which is measuring more than 65 milliseconds between different segments of the heart, or you can take all the 18 segments of the heart and take a mean and a standard deviation, and if the standard deviation is more than 40 milliseconds, then they are contracting or having mechanical synchrony at different time. In this example, you can see the septum and the free wall of the left ventricle at the base here at the midpoint. They are contracting at different points. So here is at the base. Here is the earliest, and is the compared to the septum, free wall is contracting later. Same thing at the base in a different view. This is 2-chamber, this is 4-chamber view, and this is what we call a 3-chamber or 5-chamber view. And in 3 planes, in both base and apex, you can track down the mechanical dyssynchrony, how late they are really contracting. This patient has a mechanical dyssynchrony of more than 60. Sorry, it was. More than 65 milliseconds, which is the cutoff point, and this patient responded by what is called cardiac resynchronization therapy, putting multi-site pacing and try to synchronize their time of activation and thereby synchronizing the mechanical activation. So this has helped to discern who are the responder to cardiac synchronization therapy, and this is one of the criteria which is being followed. There are patients who may have bundle branch block, their QRS duration may be less, but at the same time they may not have enough mechanical dyssynchrony, and they are usually not the responder. So here is a patient who has the mechanical dyssynchrony, which was in different segments, the same 4-chamber, 2-chamber, and 5-chamber view, but their lateral wall and the free wall and the inferior wall and the anterior wall combined together, their mechanical dyssynchrony was less than 65 milliseconds, and this patient did not respond to the CRT approach. There are about 20 to 25% non-responder, even with when you have mechanical dyssynchrony more than 65 milliseconds, and it's difficult to know who is responder if it is less than 65. So there are newer things which are coming about that who are the responder and who are not. This has been applied in a large multi-center trial study, the so-called prospective study, and they found that those who were responder, those who had a interventricular mechanical delay, means between the septum and the free wall, and if there was significant mechanical dyssynchrony, and who responded to CRT or cardiac resynchronization therapy, those who are responder at 6 months, as opposed to non-responder here, their survival was certainly improved in responder versus non-responder on a follow-up over a period of mean of 6 months, and from 3 months to 18 months total duration of follow-up. Those who were responder and their mechanical dyssynchrony moved and became less from the lowest quartile to the highest quartile, their survival also improved. So this is the lowest quartile, and this is the highest quartile. They moved the time sequence-wise, and they survived in 6 months or mean of 6 months follow-up better, significantly better than those who were staying in lowest quartile. So as a whole, we can apply the Speckle tracking, either 2D or 3D volume rendered, and we can find those who are responder and if they have responded to the cardiac synchronization therapy, resynchronization therapy, in the survival as well, the quality of life, that certainly has improved. So I think I'll stop here and just one more slide just to show that both in left bundle branch and the right ventricle apex patient, ejection fraction improved. This is the patient who has before and after CRT therapy. Before, that's the ejection fraction was about 21%. After resynchronization therapy was 32%. In patients who have left bundle branch and in patients who have right ventricle pace, in both of them they responded in the form of improving their ejection fraction as well as their outcomes. The Kaplan-Meier survival is certainly showing that they have improved outcome. So this is what the Speckle tracking and tissue Doppler has brought to the clinical arena as well as in the research arena. So I'll stop here and just say that tissue Doppler and Speckle tracking, they both have improved understanding of cardiac mechanics and helped in the therapy of cardiac dysfunction and heart failure. And thank you for your attention.
Thank you very much. Any questions and comments from the audience?
Yes.
How is the Speckle tracking actually implemented usually? Is it an automated algorithm?
So you acquire the images like in normal, we acquire the images of the heart in normal views. With certain settings, we make sure that those settings are there. Once it is acquired, then you do offline analysis. And there is software for that, and offline analysis depending on the how good images are. So it's all comes down to your image quality and your settings are fine, and then you can analyze this by tracking the Speckle. The Speckle tracking is pretty much automated now, and you can have the values come out in the graphic form, in numerical form, as well as color-coded form. So there is some degree of learning curve over there, but it can be done with after you have gone through the learning and practice.
Yeah. How do you think the cardiac, the CRT criteria right now with wide QRS and class 3, class 4 heart failure, will that benefit from adding the Speckle?
Actually, these are the patients who have been found. So there are basic electrocardiographic and clinical status criteria. Patients who have ejection fraction, means the amount of heart left ventricle squeeze, if ejection fraction is less than 35%, and there is a bundle branch block in conduction on the left side, and that gives you a wide QRS more than 120 milliseconds, those are the ones who qualify for CRT or cardiac resynchronization therapy. But in that, applying just that criteria, there are about 20 to 25% non-responder. So that criteria alone is not adequate, and that's where the Speckle tracking comes over. And you can define what's the degree of mechanical dysynchrony. So you have a patient who had left bundle branch block, has a borderline QRS duration of 120 milliseconds, and ejection fraction is less than 35%. But if your mechanical dysynchrony is less than 65 milliseconds, then probably he will fall in non-responder. On the other hand, those who are responder and those who are in a what we call New York Heart Association class 3 and 4. This 3 is very symptomatic with slight activities, and 4, class 4, is even at rest is symptomatic with a lot of breathing difficulty. Their resynchronization therapy has certainly moved the patient from 4th and 3rd class to 2nd and 1st. In some cases, class 1 and class 2. Their quality of life certainly has improved. That's the one I showed there. And those who are responded, the quality of life has certainly improved. So that's where your mechanical synchrony and which comes with Speckle tracking and tissue Doppler both that.
But do you think that the tissue Doppler, the speckle tracking, will narrow the amount of patients that qualify for CRT, D or P?
Right. So yes, and the answer is in a very recent trial, which is part 2 of the prospect trial, and there is one study which came from Mayo Clinic just last month. They showed that, I mean, there are at least 6, and some people use about 12 different criteria which you can arrive or deduct by speckle tracking. But there are 2 or 3 of them. They have very robust outcome, and you can. So, for instance, you see how much difference is between the mechanical delay between the septum of the ventricle and the free wall, and that has stood the time. And they have showed that those who have significant delay between the septal and the free wall motion, and there is a significant mechanical dyssynchrony, they were the responder. And so, yes, answer is it can narrow down to that level. But still, some of even those who fulfill the mechanical synchronic criteria, there are few non-responder in that group as well. So I think it's still evolving.
I can make a comment about the QRS duration, because the QRS is a very global measure from the body surface of the entire time of ventricular activation. But if you look from our electrocardiographic imaging data, we now have a paper that we submitted again. It was rejected, we submitted again, on 25 patients of non-ischemic cardiomyopathy. And now, it depends. So not all of those who have QRS duration greater than 120 or 130 are the same.
Right.
It depends.
Clinically,
Because it could be very skewed. Left bundle branch block is a very global statement, but the duration of the QRS can be skewed by small, because it measures the end of the QRS is the last area to depolarize in the heart. It could be some very small portion of the left ventricle in an area that doesn't really matter anything to blood pumping, and it will still prolong the QRS, but it doesn't translate to function. And I can give you an example in the other way, that a short QRS like 120 does not mean synchronization either. Now, as far as I know, in Prospect, the original Prospect, Echo also didn't win some very high marks.
The reason it did not win high marks because they did not predict rightly what's the degree of remodeling. So it was long term. But in short term, when you are going to select patient and see who is going to respond to your acute CRT, it was good. And those were the 3 parameters I mentioned about. But the reverse modeling, which happened, say like 6 months follow-up, and the same thing they showed by Mayo Clinic study, that long-term outcome means heart walls become synchronous and become less dilated and less volume. That reverse remodeling of the heart was not predicted by any of these criteria or many other criteria. I just showed 2 or 3 of them over here, but it was not predicted. So that makes difficult situation what really predicts the reverse modeling, because after all the goal is that you will do the therapy and improve the cardiac function, and cardiac function will not be in the long term improving if there is no reverse remodeling. So there, this did not win.
So can you give us maybe compare tissue Doppler and speckles, and what are the benefits of one versus the other, and especially in the context of synchronization? Is one better than the other?
Right. So the tissue Doppler is relatively more robust in the sense that there is a less reproducibility problem. So degree of reproducibility or variability of measurements are less.
This is variability between
the 2 measurements. Between inter and intra observers, so it's
or between people.
Between people, that's inter observer and intra observer. So it's a little bit less actually. is more robust. Number two, it does provide a sort of absolute value of myocardial velocity. The problem with tissue Doppler is that is affected by translational motion of the heart. So if the heart is, and also the angle of insonation means ultrasound beam. So the probe is over here, heart is sitting behind. If the heart, the area of interest you are measuring is not in the same line of the Doppler signal, then you have increasing angle of insonation, and that will create problem. Second problem is the so-called, and also the heart may move in and out of the plane of your Doppler integration. That's translational motion. And the third is, there are areas of the heart where myocardium might be dead, but the area surrounding it is moving it like it's tagged along, tethered along. So it cannot distinguish a tethering motion from a true motion. So that's where the speckle comes. The speckle provides.
Speckles can be more local.
It can provide more absolute value in that terms. Disadvantage of the speckle is, at least in our hand where we are using in other study, you cannot have a very high degree of reproducibility if you have not climbed up the learning curve, and there are many pitfalls in
Give
it.
it to two different people to
Yeah, I
analyze
mean,
it
when I
and-
started measuring, Mark will measure a different and I will measure different in the same patient, which images were acquired at the same time. And as we started analyzing and started recognizing some of the pitfalls, it became, but it comes down to one thing, how good your images are and how much the speckles are in the myocardium that you can track. So infant myocardium, for instance, or children's myocardium has less speckles as per our experience, for instance, compared to the adult myocardium, which have a lot more speckles, and you can track a lot, I mean, in a much easier fashion. So I believe there is a less reproducibility problem. So that's one thing we have come across time and again. Other thing is a strain rate, which we have not used and I haven't shown, is full of noise in some situation. If you're having too much of heart motion, it creates a lot of noise artifact. So those are the
Would
similar-
fibrosis appear as speckles? Or?
Fibrosis may not appear as a speckle, but I think it may be a less, I don't know for certain, but it might be a less speckle producing area. Certainly it will almost, if it is significant, then its contraction or contractility of that area will be decreased.